Hello everyone, and welcome to the Chronic Nerve Pain webinar. We're glad you're here today. My name is Tanya, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is co-sponsored by ourselves, CIRPD, and Pain BC in collaboration with the Canadian Pain Coalition. It's made possible through the support of Community Gaming Grant through the BC government, as well as donations and memberships to our organization. As I mentioned, my name is Tanya, and I'm moderating the webinar and handling the Q&A session today. And our presenter today is Dr. Dwight Moulin. Dr. Moulin is a professor in the departments of Clinical Neurological Sciences and Oncology at Western University, and he's also the Earl Russell Chair of the Western Pain Program. He chaired the Neuropathic Pain Special Interest Group of the Canadian Pain Society from 2005 to 2014 and led the consensus statement on the pharmacological management of chronic neuropathic pain, initially published in 2007 and updated in 2014. And we're very glad to have you here today, and Dwight, I will hand it over to you.
Thank you very much, Tanya. It's a pleasure for me to talk to all of you about nerve pain and what is nerve pain and how we manage it, and how we can improve the quality of life of individuals who are afflicted with nerve pain. And so I will go through some of the aspects of nerve pain and try and simplify it as much as possible and indicate the various treatment options and the risks and benefits of these treatment options, and how we can improve the management of pain and the setting of nerve injury, and also at the very end talk about some of the things that are going to be coming up in the near future regarding further improvements in our management of nerve pain. So I'm a neurologist, and I see individuals who have nerve pain, and it's a big part of my practice and an area of my work that I thoroughly enjoy, including the research. So this first slide is just meant to provide some context about nerve pain, and this is just a diagram to illustrate what the nervous system is comprised of. And you can see that this is a figure that's showing the brain and the spinal cord, and we refer to this as the central nervous system, and all these smaller nerves coming off the brain and spinal cord, for instance, going to the arm, is the peripheral nervous system. So the nervous system is composed of these two parts: central nervous system, which is the brain and spinal cord, and the peripheral nervous system are all these smaller nerves going out to the extremities and to the trunk. And basically, what we refer to as nerve pain or neuropathic pain is any injury to the central nervous system or the peripheral nervous system. And we will have many examples of these that will illustrate the kinds of problems that patients have with nerve injury. Just to provide even further context, this is a form of chronic pain, but there are other much more common kinds of chronic pain. And so pain related to injury to joints, commonest being arthritis or back pain or even headache. So-called musculoskeletal pain accounts for about 90% of individuals with chronic pain, and the most common type would be chronic back pain. Nerve pain represents only 10% of individuals who have chronic pain, but it can be particularly severe. And fortunately, we do have medications that target nerve pain in particular. So here is an example of several examples, in fact, of individuals with nerve pain. And the first heading of this slide, it says that 5 to 7% of the general population have neuropathic pain. I'm going to add to that and discuss in brief the entity of fibromyalgia, which is a special form of nerve pain, probably due to a chemical imbalance in the central nervous system. And 2 or 3% of the population have fibromyalgia. So if we add that to what we have in the general population, it comes out to about 10% have nerve pain if we include fibromyalgia. Much more common causes of nerve pain are illustrated in the second and third bullets and the fourth bullet. And so individuals who have shingles, especially over the age of 50, are prone to persistent nerve pain. And so shingles is a condition related to reactivation of the chickenpox virus that we all harbor in our nervous system, and it has a tendency to start cropping up again, especially over the age of 50, and these patients with shingles over the age of 50, sometimes the pain persists, and it can persist for months, and up to 50% of individuals will have pain that persists for at least 3 months. The good news is that this pain that we refer to as post-herpetic neuralgia, or PHN, usually resolves over the first year or two after the development of shingles. And so if somebody has lingering pain after shingles and it's been there for 2 years, it's probably not going to go away, and that individual needs to rely on treatments, including medications that might help individuals to live with the pain. Another example of nerve pain, which is fairly common, is pain after breast surgery. And after breast surgery, with breast surgery, nerves have to be cut in order to remove the tumor, and this almost always results in numbness in the armpit area and also the over the scarf or the breast area. And 20 or 30%, and mostly women, will have persistent pain after breast surgery due to cutting of these nerves. And we refer to this as post-mastectomy pain. Another classic example of nerve pain is that associated with diabetes. And we all know that diabetes is becoming more and more common as the population ages, and also rates of obesity are increasing, which predisposes to the development of diabetes. And 10 to 20% of individuals with diabetes will have nerve pain, and that's usually in the hands and feet related to irritation of nerve endings. So these are some common examples of the kinds of nerve pain that I would see in my practice, or that a family doctor would see in their practice. This slide is just meant to indicate that sometimes we see patients who have a mixture of both musculoskeletal pain, and we refer to this as nociceptive pain, as well as nerve pain. And these intersecting circles where it says mixed pain helps us to remember that some individuals have both musculoskeletal pain and nerve pain. And the best example of that would be somebody who has disc herniation or a slipped disc in their low back area. So these individuals commonly have chronic aching back pain, but because the disc material is pinching a nerve root, they have sciatica as well, with pain radiating down their leg. So a combination of both back pain, or what we refer to as nociceptive pain, and nerve pain, they coexist in many individuals who have sciatica. So we have to recognize this and treat both their back pain and the nerve pain due to sciatica. Here's an example of one of the classic nerve pain syndromes that I spoke about. And this is a lady that I met about 12 years ago, and at the time she was suffering from terrible pain. But this is a picture that she took of herself. This is a selfie from a long time ago. She took a picture of herself with when her nerve pain erupted, and you see this reddish blister-like area involving the left forehead and her nose and around the eye, and this is shingles. So when you see somebody who has a shingles rash, you can appreciate how painful this would be with all this inflammation. And she took this picture of herself 2 years before I saw her. And when I saw her 2 years later, this is what she looked like. And it's hard to believe that this is the same individual 2 years later, and she looks perfectly normal. And even though the rash had healed and she had very little scarring in the left forehead area, she still had severe pain where she had that rash. And she was one of these unfortunate individuals where the pain persisted for 2 years and longer after the development of shingles. And so she would be a perfect example of somebody that I would see who has nerve pain, and this would be a classical form of nerve pain. And what this illustrates is that, and all of you would know this who are suffering from pain, is that on the outside you can look perfectly normal, but on the inside have severe pain, and there's nothing objective. So we have to rely on what patients tell us, because very often with chronic pain, there's nothing external that helps to objectify or validate the pain. We have to take it at face value, and that's one of the first principles of managing pain, is pain is whatever the patient says it is, because there may not be anything objective to help us validate that pain. And so she had the classic symptoms related to nerve pain. And nerve pain produces very specific symptoms very frequently, and there are 3 of them. And so this lady illustrated all 3 of these components of pain. When nerve injury occurs, these patients commonly report a sense of burning. The area is on fire. It's as if their arm or leg was dipped in boiling oil. That's how some people will describe it. So it's a constant burning pain, and they feel that burning pain in the area of nerve damage. So wherever the nerves were coming from to provide what would be normal sensation, if that nerve is damaged, that area translates to steady burning pain. The other common symptom of nerve injury is the development of shooting, lancinating pains, and these are just like electric shocks that jolt an individual, and they can occur at rest or in response to moving or even touching the area. So burning pain with the superimposed shock-like pain, these are the classic features of pain after nerve injury. And the third component of pain after nerve injury is what we call touch-evoked pain, and the technical word for that is allodynia. And what this means is that the nervous system gets mixed up, and as a result of this nerve injury, and the message sent to the brain isn't normal, because if a person who's had nerve injury, just light touch in the area of their pain, instead of feeling like a normal light touch, becomes a very painful sensation, so that it can make the burning pain worse or set off one of these electric shocks. So the skin becomes extremely sensitive. And some people with nerve pain, and a classic example would be this lady with pain after shingles, or if the shingles affects the chest wall, even a breeze or air conditioning can set off the pain and make it much worse, because their skin has become extremely sensitive. So basically, nerve pain is an example of a state where the nerves become extremely irritable. So we refer to this as heightened irritability of nerves as a result of nerve injury, and it leads to this ongoing pain and all the disability associated with it. And we have to reflect on that and realize that these associated symptoms, and those of you living with pain will be very much aware of this, it isn't just the pain that impacts individuals. It has all kinds of ripple effects, secondary effects. So this slide is just to help remind all of us that when a person is suffering from chronic pain, and not just nerve pain, it can be back pain or chronic headaches, is that understandably this can get people down. So depression is common, anxiety is common, being irritable is a very frequent symptom, and this is associated with some of the things on the left side of the slide in terms of physical functioning. We all know what it's like if we can't sleep at night, and after 2 or 3 nights of not sleeping, we're all irritable. And if you can, I can imagine individuals that I see frequently who haven't had a good night's sleep for months or years, good reason for them to be irritable. And so it's difficult for them to communicate and associate with family and carry on social functioning. So all of this has these major ripple effects with sleep disturbance and fatigue, decreased mobility because it hurts to move, decreased social functioning with family, and disability and loss of work and loss of employment, and sometimes getting into trouble with drugs if a person uses drugs excessively to try and cope with their chronic pain. So these are all things that we have to address as well. And so when we're thinking about the drugs that we're going to talk about for nerve pain, some of these agents that are strong painkillers are also antidepressants. So if somebody's got nerve pain and depression is a major problem, I will use an antidepressant that's also a strong painkiller because it might tackle both issues. There are other drugs that are anticonvulsants that help to relieve anxiety. So if anxiety is chronic anxiety is a major component of their pain, I might use certain anticonvulsants that will also help to relieve the anxiety. So we have to address all these other issues and not just the pain. This is just a slide to help us reflect on what makes these nerves irritable. So this is a figure, and what it shows is both the peripheral nervous system on the right side, and you can see this peripheral nerve with the little red dots on it, and this nerve goes into the spinal cord where there's a big red dot, and then the information from there goes up on the extreme left of that slide up to the brain to register as pain. And what happens after nerve injury, whether it's due to a slipped disc with the pinching of a nerve, or it's after surgery with scar tissue on the nerve that can happen in breast surgery, whether it's due to diabetes or due to shingles, is that nerves become irritable, and these little red dots are meant to show sodium channels, and sodium channels are a major cause of nerve irritability. And so we need drugs that dampen down sodium channels in these irritable areas in the peripheral nerve, and that big red dot in the spinal cord is meant to reflect on other areas of irritability. So even after an injury to the peripheral nerve that we might see after shingles or diabetes, it also has secondary effects on nerves in the spinal cord that also become irritable. And we have to tackle all of these areas of nerve irritability to help relieve pain in individuals who have had a nerve injury of one kind or another. I want to mention as part of this, because I've now started to incorporate this entity of fibromyalgia as a special form of nerve pain, and we have good evidence now that fibromyalgia is due to a chemical imbalance in the central nervous system, in the brain and spinal cord, that's responsible for widespread pain in these individuals. This is mostly women. It's 95%, occurs 95% of the time in women, and we're not sure why that is the case, but fibromyalgia is a state of generalized pain, and the skin and muscle, soft tissues become very sensitive, and they develop excessive tenderness in the soft tissues. These patients often have disruption of mood, so anxiety and depression are common. Fatigue is common, and also sleep disturbance is also very common. And even if a person with fibromyalgia seemingly sleeps for several hours, they don't wake up feeling refreshed. They feel as if they've only got a couple of hours sleep, and they have trouble getting beyond this. So fibromyalgia is a very real entity, and fortunately now we do have some treatments that are useful for fibromyalgia, and so this is a condition of a chemical imbalance in the central nervous system, so we can think of it as a form of nerve pain. And as I said, this occurs in 2 or 3% of the population, mostly women. And family doctors will see patients with fibromyalgia in 5 or 6% of their patients, but these patients are sent to specialists like rheumatologists. It's a much more common thing for specialists to see because they commonly get referred to rheumatologists and other specialists to try and provide treatment. And I'm going to talk about some of these agents in general regarding the classical forms of nerve pain, but we fortunately now have two drugs that are useful for fibromyalgia. One is duloxetine, which is an antidepressant, and the other is pregabalin, which is an anticonvulsant type drug. But both of these agents dampen down irritable nerves. And one important thing to remember in general about treating nerve pain, whether it's fibromyalgia or actual nerve injury, is that the goal is just to make the pain bearable. These drugs never take away the pain completely, and so it's not realistic to think about a cure. They're just meant to make the pain bearable. So what we try and do when we manage nerve pain is get the pain below a level of 5 out of 10. So a 2 or a 3 or a 4 out of 10 is all we can expect. We can't get the pain level to 0, but we try and get it below 5 out of 10 because most people will say, whatever that means to the individual, if we can get the pain below a 5 out of 10, they can get on with their life. But when pain is over 5 out of 10, it really interferes with a person's life and they have difficulty functioning. So we have 5 classes of agents that we use for to manage nerve pain, and these are all agents that have been addressed in scientific studies, and so this is evidence-based in good scientific studies showing that these drugs are particularly useful for nerve pain. So the first category is drug I've already spoken about, gabapentin and pregabalin. These are cousins of each other, have the same mechanism of action, and they dampen down irritable nerves. TCA stands for tricyclic antidepressants, and that would include drugs like amitriptyline and nortriptyline. And the SNRIs are another category of drugs. This is known as serotonergic, noradrenergic reuptake inhibitors. The name isn't particularly important, but duloxetine is an example of an SNRI type drug that's useful for various types of nerve pain and fibromyalgia. People who have pain after shingles, where the pain is localized to a certain area of the body, we can have patients apply local anesthetic. So lidocaine is the agent that a dentist might use to deaden the nerve to do dental work. This lidocaine is a local anesthetic that dampens down irritable nerves. And so 5% lidocaine, either as a gel or like a paste or a cream or as a patch, applied to the area of sensitivity of the skin can be very useful. So applying topical lidocaine to the forehead in a lady who has the kind of pain that I mentioned before, or to the chest wall, or even in the feet in somebody who has pain due to diabetes, they put it on overnight and it can dampen down these irritable nerves. Another category of drug is tramadol, which is a drug that has some of the properties of a morphine-like drug. It's a weak morphine-like drug, but it also has properties of the antidepressant type drugs to dampen down irritable nerves. And then for severe pain, some patients benefit from major painkillers, so-called narcotics or opioid analgesics. And this is just a diagram to illustrate how one example of how this kind of drug works. So this animated slide showing this burst of nerve impulses is meant to show nerve pain coming from an arm or a leg going into the spinal cord. So this brown area in the middle is the spinal cord, and so this is meant to represent a burst of nerve pain coming into the spinal cord. And what that does is get transmitted across the spinal cord, and it goes up to the brain and is perceived as being painful. Some of the drugs that we use to treat nerve pain, including the antidepressant type drugs, activate another pathway. So this green burst of energy coming down from the spinal cord goes into this nerve that's in the spinal cord, and this green projection actually comes from the brain. And this is a pathway that, when activated, blocks nerve impulses from getting through and getting to the brain. And the antidepressant type drugs are particularly effective at enhancing or magnifying this projection from the brain, this green pathway, and it shuts off this descending pathway from the brain, and it shuts off these nerve impulses that are coming from the peripheral nervous system. So this is an example of how one class of drug, the antidepressant type drugs, work to block nerve pain. And so an older class of antidepressants are the so-called tricyclic antidepressants, and there are several examples of them on this slide. On the left, you can see the different types, amitriptyline and down to nortriptyline. Amitriptyline is a drug some of you may be aware of. If a person says that their pain is worse at night and they can't sleep, sometimes I'll use amitriptyline, and this slide shows that some of the side effects of these drugs. So under sedation, you can see 3+ for amitriptyline. So amitriptyline is a good drug because it makes people drowsy and helps them to sleep at night, but sometimes it also makes them dopey the following morning. But for some individuals, a low dose of amitriptyline, like 10 milligrams or 25 milligrams, can allow them to sleep and still have pain the following day. But you can see that it also can produce weight gain, and it can lower blood pressure, and rarely it can cause seizures. So another popular antidepressant type drug, if the pain during the day is predominant, I like to use nortriptyline as the drug at the bottom because it doesn't have as many side effects. These are fairly safe drugs that can be used to manage neuropathic pain. And if we look at the side effect profile of all of these drugs that we're talking about, the tricyclic antidepressants, the pregabalin and duloxetine and tramadol, they almost all, well, virtually all of them can cause drowsiness, and they can cause confusion, and they can cause unsteadiness or weight gain. And so these are the common side effects of these drugs, and our goal always is to try and find a drug or a combination of drugs that relieves nerve pain with minimal side effects. These are all side effects that can occur, but some patients have no side effects, and others might have side effects at higher doses, but we can usually find a dose that they can tolerate that helps to relieve their pain. The one class of agents that I mentioned are the so-called narcotics or morphine-like drugs, and we refer to these as opioid analgesics. And the desirable effect that we want to take advantage of when we give a morphine-like drug is analgesia or pain relief, and then secondarily relieving anxiety. But on the right, you can see all the possible side effects of using narcotic-type drugs like morphine. Depression of breathing or respiratory depression is the most serious side effect, but fortunately that's very, very rare. But narcotic-type drugs, like all the others, can cause mental clouding. They can cause nausea. We have to treat constipation. And we have to recognize that when an individual goes on a morphine-like drug, we refer to this phenomenon of physical dependence. And that means when somebody comes off a drug like this, say they get pain relief with for another reason, or the pain goes away, you can't stop these drugs suddenly. They have to be withdrawn slowly, because if they're stopped suddenly, cold turkey, they can have a withdrawal reaction. Something that's less common, but we also have to recognize, is that if we use a narcotic-type drug to treat pain, a small segment of the population, perhaps 10 or 15%, are at risk of developing something totally different called psychological dependence or addiction, which is entirely different, and this is craving for the drug. Even if the drug causes harm, if somebody becomes addicted to a morphine-like drug, this can cause a major complication with addiction, and we have to monitor for this and treat that appropriately if it happens to occur in an individual who's placed on a morphine-like drug for their nerve pain. One special morphine-like drug that I like to mention because it's sometimes useful is methadone. Now, methadone is a drug that most people recognize as being used to treat people with problems with drug addiction because it decreases their craving for heroin and other drugs. But methadone in itself is a strong and can be a very useful painkiller for individuals who have nerve pain. The third bullet illustrates a property of methadone, a technical term that indicates that it has this NMDA antagonist activity. So it has special properties that block nerve pain. So some individuals will benefit from going on methadone. Has nothing to do with treating addiction. It's just that it can be a very potent and useful painkiller for some individuals with severe pain. And this just illustrates a study that we did 10 years ago now in a series of patients that we had, showing that individuals that go on methadone. I only use methadone when nothing else works. And at that time I had about 50 patients. I have even more now, and half of them methadone was working very well when nothing else worked. So I found it to be a useful drug in some individuals with nerve pain. Another type of agent that's emerged as being useful for nerve pain and other types of pain, there's a lot of talk about this now in the media, are the marijuana type drugs. Either marijuana itself, which is, whether it's smoked or ingested, is a combination of at least 50 different chemicals. And so marijuana has special properties, and marijuana is definitely a painkiller. It can cause sedation and lethargy, but it has properties that block nerve transmission, and so we know that it's a good painkiller for some individuals. And we have synthetic forms of marijuana that are available in pill form or in a spray. And this is just meant to illustrate a formulation of a spray. It's a formulation, the trade name is Sativex, and it's a spray that's put in the mouth, and it's absorbed through the mouth, and it's approved in Canada, especially for the pain associated with multiple sclerosis. So that marijuana and its derivatives are a type of a class of drugs that are useful for some individuals who have particularly severe nerve pain. So to get back to our individual with this severe pain in her forehead as a result of what we refer to as pain after shingles or postherpetic neuralgia, how would we treat somebody like this? Well, we have what we refer to as an algorithm, and this is based on scientific literature that gives us a roadmap to how we would manage nerve pain. It's sort of like an instruction manual that we all carry around in our heads when we're managing somebody who has nerve pain. And so each of these boxes illustrates different types of medications that we use for nerve pain. So the first box at the top is what we refer to as first-line treatment for nerve pain. And TCA refers to tricyclic antidepressants like amitriptyline or nortriptyline. Gabapentinoids refer to the type of drug that I mentioned, gabapentin or pregabalin. And SNRI refers to another type of antidepressant, and that's illustrated by duloxetine. And so all of these drugs are comparable, and they're first-line drugs for the management of nerve pain. Sometimes we'll combine an antidepressant like pregabalin with duloxetine as first-line treatment for nerve pain. And that to the right of this slide, to the right of that downgoing arrow, where it says add additional agents sequentially if partial but inadequate pain relief, sometimes patients will say, well, my pain's gone from a 9 out of 10 to a 6 out of 10, and I'm really happy about that, but it's not good enough for me to allow it to have better function and to have overall better quality of life. And so we'll maintain them on, say, duloxetine or pregabalin, but then we have to add another agent. And we'll add another agent like tramadol or even a major painkiller like morphine. And the goal is always to try and get the pain below 5 out of 10. Some individuals, we will add a marijuana type drug, either a synthetic pill form or for somebody, say, with severe pain due to multiple sclerosis, we might give them a medical marijuana exemption or card to add to their pain relief. And so the lady that I saw with the pain from shingles, she was on duloxetine, and then I added a low dose of morphine, and she's been on that for 10 years now, and it's kept her pain under 5 out of 10 and has allowed her to carry on her life, and her dose hasn't changed in years. And she's very grateful that she's been able to get pain relief with a combination of these agents. The very bottom where it says fourth line agents, these are other drugs that we use when all the other ones don't work. And so these fourth line agents include methadone that I've already talked about, and some of the other anticonvulsant type drugs. This slide also shows with the asterisk down to the bottom left this topical lidocaine. Using lidocaine or local anesthetic freezing on the skin can sometimes relieve the pain, especially after shingles, or what we refer to as post-herpetic neuralgia. So what I've talked about so far are the things that any physician or family doctor or specialist can use to manage nerve pain, and they work 50 to half to 2/3 of the time, but not everybody gets relief or can tolerate medications given by mouth. And so there are a bunch of other modalities that are available, usually that have to be prescribed or administered by specialists. So somebody who has a pinched nerve in the back and has sciatica, sometimes injecting a cortisone type drug into the back can be useful. Sometimes we use this lidocaine drug, local anesthetic, even as an intravenous infusion, can sometimes be useful for nerve pain. Some patients benefit from different types of nerve blocks, including blocking the sympathetic nervous system, especially for a rare condition called RSD, or reflex sympathetic dystrophy, or what we now refer to as complex regional pain syndrome. And one of the techniques that's particularly useful for nerve pain, which requires minor surgery and usually referral to a neurosurgeon, is spinal cord stimulation, where a wire is passed through the skin up against the spinal cord, and it causes tingling in the area of pain, and that tingling blocks nerve impulses so that the person feels the tingling instead of the pain. And so spinal cord stimulation can be useful for some individuals who have intractable pain and don't respond to various pain medications that we might administer by mouth. And so what do we have in the future? Right now we can control nerve pain, get the pain under a level of 5 out of 10 in perhaps 50% to 2/3 of patients. And when drugs don't work and these other techniques don't work, sometimes mind over matter techniques are useful. So we have a pain psychologist that will work with individuals and use mind over matter techniques, including meditation and other forms of psychological treatments that can help relieve pain and also help people to cope with pain. The first bullet refers to something that's no longer in the future. There's good evidence now that all individuals over the age of 60 would benefit from a vaccine. This is a special vaccine that prevents shingles from developing, and so we do have a vaccine now that can prevent nerve pain. So there is good evidence that the vaccine against shingles or the zoster virus can prevent the development of severe pain and post-herpetic neuralgia. So this is advised now in people who have never had shingles over the age of 65. The downside is that this vaccine costs at least $150. So that's something to be aware of, but it can be useful to prevent nerve pain. And then the second bullet just refers to a lot of studies that are going on now involving brand new drugs that might be even more effective for nerve pain than we have now. And so I suspect that these new drugs are going to be available in the next 5 to 10 years. Maybe some of them might be available even in the next 2 or 3 years. The downside is that although they may be very effective for nerve pain, these new drugs are going to be particularly expensive, and that's going to be a limiting factor for many individuals. So that's the end of my formal presentation. It's just meant to review what nerve pain is, the various drugs that are available to help treat it, some of the other techniques that can be used when oral medications are no longer useful, and some of the things that are available now to prevent nerve pain, and some of the things in the future that are going to be even more effective than what we have available now. So we have some time for questions that I think may have come in, and I'll try and answer these to the best of my ability. So Tanya, I'll turn it back over to you.
Great, thank you very much. That was a very good presentation with a good synopsis and overview of what's going on and what can be done for people. Thank you for that. And let's see, one of the first questions we got was from a patient who has chronic nerve pain that comes in and out. So they'll have days where it's fine and then days where it's bad, and just wondering why it is that chronic pain can be so intermittent like that.
Well, that's a good question, and when nerve pain occurs, it causes irritability of nerves, and sometimes this irritability just comes and goes. A good example of that, in this individual, I don't know specifically the kind of pain this person has, but there's one specific type of nerve pain that's particularly severe, and it's called trigeminal neuralgia. And this is shock-like pains in the face that some individuals, older individuals, can get, and it's due to a pinched nerve that's coming from the brainstem. And sometimes a pinched nerve will cause nerve irritability, and that nerve irritability will come and go. And that's just a characteristic of nerve pain, is that that irritability can be present and cause severe pain. It can get better, and then it can come back again. So that sometimes occurs in nerve pain, especially this particular type of pain in the face that we refer to as trigeminal neuralgia.
All right, and then a health professional says they have a patient with pain and numbness that was after a blown IV from surgery, and that it's been over a year and most of it has been resolved except a little bit of C5, C6 dermatome distribution around the wrist, and wondering how long that might take to fully heal, and when should a healthcare provider send someone on to a neurologist for further assessment?
So after intravenous, there are two mechanisms for pain occurring after something that should be fairly simple, and this would be unfortunately a very rare complication. So sometimes an intravenous or even an injection can actually hit a nerve and cause this nerve irritability. So how long will it last? The only good model that we have for nerve pain is this model of pain after shingles, because that's been studied and patients have been followed meticulously after shingles to see how long the pain lasts. And using shingles as an example of nerve injury, if the pain is there at the 2-year mark, it's probably not going to go away. And so there are many other different types of nerve injury pain, including trauma or even after an IV or disc herniation. But if we use that as a model, if the pain is there at the 2-year mark, probably even after 1 year, but especially after 2 years, it's probably not going to go away. And if there is an issue of what's causing the pain, then it would be appropriate to send that individual to a neurologist. But if the cause of the pain is fairly clear, it would be more appropriate to send that person to a pain clinic, or and some neurologists are pain specialists, and that's what I do. And the approach would be just what I've outlined. The other type of pain that can occur after even an IV is what I referred to as this reflex sympathetic dystrophy or complex regional pain syndrome, where the pain actually spreads beyond that particular nerve distribution, and that requires special treatment. And if seen early, sympathetic blocks can be useful, or sometimes the spinal cord stimulation that I've already talked about.
All right, and then someone else had a question. Some people group, or some doctors group, chronic fatigue syndrome in with fibromyalgia, and others treat it as a separate condition. What's your view on CFS, and does it fall within the boundaries of neuropathic pain and involve a chemical balance as well?
So there are individuals who have chronic fatigue syndrome. It's real. Nobody wants to be fatigued all the time. They're not making it up. Profound fatigue is probably due to some type of chemical imbalance, and sometimes it goes with widespread generalized pain. So this condition of fibromyalgia is a state of widespread generalized pain, and most of them have chronic fatigue syndrome. But chronic fatigue syndrome can exist on its own, independent of pain. I think the link is that somebody who has chronic fatigue syndrome is probably at greater risk of developing chronic pain after injury. So somebody with chronic fatigue syndrome, if they have a whiplash injury or some other soft tissue injury, are probably more likely to have persistent pain than somebody that doesn't have chronic fatigue. But chronic fatigue syndrome in itself is not painful. It's a state of chronic fatigue, and I wouldn't refer to that as a form of nerve pain or neuropathic pain, because they don't have pain, they just have the fatigue, but they are often linked.
Okay, very good. And any thoughts about ultrasound-guided injection of analgesic in PHN in pudendal nerve pain?
So ultrasound is just bouncing sound waves off the body, and it can guide an anesthesiologist. These are the anesthesia doctors are the ones that usually do nerve blocks, and so ultrasound can guide an anesthesiologist, and so that they can provide the injection exactly where they want to go, to provide a particular nerve block. So it's a very useful technique to be sure that the needle is going exactly where you want it to go, not only to relieve the pain, but also to prevent damage to other tissues. So ultrasound-guided nerve blocks are very useful, and the specific example of a pudendal nerve pain is a pain in the perineal area or genital area, and that's the distribution of the pudendal nerve. So sometimes nerve blocks are useful, and if someone is doing a pudendal nerve block, most anesthesiologists will do it with an ultrasound guidance so that they know exactly where they're going, and they're putting the local anesthetic or whatever else they're injecting into the right spot.
All right, and there have been a couple of questions for references to some of the facts that you've discussed, particularly around the fibromyalgia being neuropathic pain and some of that newer research. Would you be willing to provide that to me after the presentation so that I can then pass it on to everyone who attended?
We have a recent paper, Guidelines on Managing Neuropathic Pain, that was just published last year, and I can send that to you. It doesn't specifically talk about fibromyalgia, but I think there are references there, and I can also provide some other references that might help in that area.
Perfect. That would be wonderful. And then a couple of questions about some of the drugs. You referred to neurotriptyline as a strong analgesic. What is the evidence that neurotriptyline, amitriptyline, or any other antidepressant is a strong analgesic? And what does that term mean?
So nortriptyline or amitriptyline are examples of these class of drugs that we call tricyclic antidepressants. And these drugs have been around for 30 or 40 years. And these are drugs that in low doses, and by low doses I mean, say, 25 to 50 milligrams a day, can relieve nerve pain. If these drugs are used to treat depression, the doses are usually over 100 milligrams a day. So low doses of these drugs can relieve nerve pain. And there are at least 20 very good scientific trials showing that these drugs provide substantial relief from nerve pain, where about 1 person in 3 gets substantial relief of nerve pain. So this class of drugs, there's probably more evidence for benefit from this class of drugs for nerve pain than any of the other ones that we've talked about, because they've been around a long time and there have been many, many scientific studies to show benefit using these drugs.
All right. And what is the long-term effectiveness of gabapentin, and does the effectiveness have a reduced effect over time?
That's another good question. So gabapentin and pregabalin are drugs that dampen down irritable nerves. And this is a class of drugs that if they work, the drugs themselves, they don't develop tolerance. So tolerance is a term that refers to the fact that in some individuals with certain drugs, increasing doses have to be used over time in order to provide the same degree of pain relief. And that sometimes occurs with morphine-like drugs, but there's no evidence that it occurs with drugs like gabapentin. So if somebody's on, say, gabapentin or pregabalin, and they've had pain relief for months or years and the pain is getting worse, it means something else has happened. If there's increased anxiety due to whatever's going on in the person's life, that can make the pain worse, or the underlying causes of the pain, it may have progressed. But if if somebody has pain control with gabapentin or pregabalin, and the pain becomes worse, it's unlikely to be due to the drug no longer working. Something else is going on.
All right, and then a similar question, but for spinal cord stimulator and the long-term effectiveness of it. Say you're using it for lifelong pain management and do regular maintenance of leads, etc.
Yes, and so spinal cord stimulation helps, again, doesn't cure the pain, but helps in about 50% of patients that are tried with spinal cord stimulation. And there are lots of studies now where people, or hundreds or thousands of patients who say, yes, this is helping me, and they've been followed for months or years, out five or 10 years with sustained pain relief. So somebody that gets relief with spinal cord stimulation can have long-term pain relief. But one of the problems with spinal cord stimulation is that these wires have to be inserted through the skin into the certain area of the spinal cord, and sometimes the electrode that's touching the spinal cord or the surface of the lining of the spinal cord can move. And if it moves, they no longer can feel that tingling in, say, their arm or leg, and they don't get pain relief. And so about 1/3 of the time in individuals who've had pain relief, and overall it's about 1/3, just with movement or over time, the electrode will move or migrate, and the surgeon has to go back in and reimplant it or revise it so that it captures the right area again. So spinal cord stimulation does provide long-term pain relief, but if the wire moves, that pain relief can be lost, and then they need another operation or a reprogramming to try and again capture the area of pain and reproduce that tingling that relieves it.
All right, and then there have been a couple of questions about small fiber neuropathy and what causes variations in SFN.
So small fiber neuropathy is a form of nerve pain, and most of the time when patients present with small fiber neuropathy, very frequently, I would say at least 50% of the time, we can't determine the cause. And what this refers to is that there are two types of pain nerves. There's larger pain nerves and there's small pain nerves. And small fiber neuropathy refers to irritability of small pain nerves, where the nerve endings become particularly irritable. And there are tests that can be done, and even a skin biopsy that can confirm that there's damage to these small nerves, but most of the time we can't find the cause. And it presents just like other forms of peripheral nerve pain. They get pain in their hands and feet, and we treat it with the same drugs that we've already talked about, but most of the time we can't determine the cause of small fiber neuropathy. There are even some individuals who have widespread pain, and so some individuals who are labeled as having fibromyalgia, if they have the skin biopsy to look at their nerve endings, they actually have small fiber neuropathy. So there's an overlap between small fiber neuropathy and fibromyalgia.
All right, and then You mentioned in your presentation about oftentimes people are referred to also going to psychologists or therapists to do some of the, more coping skills and managing the pain in that manner as well. Do you have do you know of other evidence for other alternative treatments such as acupuncture, massage, light exercise, that sort of thing?
Yes, there's evidence for some complementary treatments. Most complementary treatments that you might go to a health food store, most, not all, but most of these agents are harmless. It's just that 99% of them have never been studied, and so we don't have evidence that they're of benefit. And there's hundreds of health food store medications and agents and that people can try, but it's just that they haven't been studied. And so that's all we can say about them. But things like acupuncture can be useful for nerve pain, and there's some evidence that it's useful, and also massage, just general exercise, keeping as active as possible can also help to relieve nerve pain. So there is some evidence for some complementary treatments, but for most of them we don't have evidence. And I always say to patients, if an agent is not dangerous and it's affordable, then I tell patients go ahead and try it, because if it works, that's great. It's just that for most of them there's just no scientific evidence one way or the other.
All right, and then another question: what is your outlook or opinion on using an IV ketamine treatment?
Yeah, so one thing I didn't mention, it would be under the category of that slide where I showed various types of injections. Ketamine is an anesthetic that's normally used to treat individuals to put them asleep so that surgery can be done. And so ketamine is a very good anesthetic agent in the operating room, but it has this property that I alluded to with methadone, this property, the technical term, this NMDA antagonist. And so ketamine is a drug that can be used in lower doses than would be used in the operating room as an infusion, and it's sometimes useful for nerve pain when nothing else works. It's particularly useful in individuals who have a rare cause of nerve pain called this reflex sympathetic dystrophy, or RSD, or what we now call complex regional pain syndrome. So intravenous ketamine infusions are used sometimes with local anesthetic for particularly intractable nerve pain. And sometimes the doses that are used can make people very drowsy. They can make people hallucinate and become quite confused. But doses are anesthesiologists try and use doses that can make people drowsy but provide sustained pain relief after the infusion is finished. And in some centers now, they'll provide a fairly high dose ketamine given daily for 5 days in a row, and that sometimes can relieve severe nerve pain for 2 or 3 months at a time. So ketamine is something that can also be useful for a particularly bad nerve pain.
Okay, and just a quick follow-up question to that one, and then I think we'll probably end the session. But someone was asking, they've seen some patients who have been given intravenous lidocaine infusions, and it doesn't seem to work. In what percentage have you seen that as useful?
So this is very patient dependent. We're actually studying this now, but across Canada and the United States, there are patients who will receive an intravenous infusion of lidocaine. It takes about 45 minutes, makes them a bit drowsy, and some people will get pain relief for 1 or 2 months after each infusion, and they come back to the pain clinic every couple of months for another infusion. And there's no way of predicting who's going to respond and who doesn't. We're not even sure it has anything to do with the local anesthetic. In some individuals, just the act of infusing a drug intravenously causes what we refer to as a placebo effect, and it gives them good pain relief. And it really doesn't matter to the patient whether it's the local anesthetic itself or this placebo effect. The bottom line is that it works for some people, and if it works, then we keep providing it.
Great. All right. I think we're going to go ahead and close down because we are right at about time. But thank you everyone for attending and for participating in the questions. We're very glad that you were here with us today. And thank you very much, Dr. Moulin, for your presentation. That was really great.
Okay, and thank you for hanging in there, and I'm very happy to do this presentation for you.
Wonderful. Thank
Bye-bye.
you.
Okay, bye-bye.